Hello, good evening, all. Today we are going to talk about enterocutaneous fistula. And enterocutaneous fistula is an important disease condition in surgical practice. And the knowledge of enterocutaneous fistula is very important for adequate patient management because this is a disease condition that is associated with high morbidity and mortality. So it is very important. We appreciate how they present and the details of the management of this condition. And after we discuss, I'm going to give a clinical scenario of one of the patients we managed and the various challenges we faced. And this is very important in citing a case so that you will really appreciate how difficult it is to manage such a condition. Now, by way of introduction, you should know a fistula is an abnormal communication between two epithelial surfaces lined by a granulation tissue. So if you define fistula as abnormal communication between two epithelial surfaces, then an enterocutaneous fistula will be the communication between the intestine and the skin, resulting in discharge of intestinal contents onto the exterior. As mentioned earlier, it is associated with high degree of morbidity and mortality due to myriads of complications and challenges in managing such patients. Now, when you are managing a patient with enterocutaneous fistula, it's really distressing to the patients, the relatives, as well as you, the surgeon. So it requires commitment in all those involved in the management. So adequate counseling is important for both the patient and the relatives. Because when a patient is well motivated about the management of his disease condition, they really show good cooperation. And of course, they are psychologically prepared for the challenges involved in this management. So how is enterocutaneous fistula classified? Basically, they can be classified into physiologic, anatomic, and etiologic ways. And this is essential for you to know how to approach this fistula. The physiologic classification of enterocutaneous fistula is based on the volume of effluent in 24 hours. It is important for planning a non-operative regimen or conservative treatment for fistulas because if it is a very high output fistula, you know it is going to be difficult to treat patient conservatively. In fact, it will fail. Now, in low output fistula, they tend to respond well to non-operative treatment. So high output enterocutaneous fistula is defined as a 24-hour effluent of more than 500 mils, while low output enterocutaneous fistula is defined by a 24-hour output of less than 500 mils. Okay. However, this cutoff differs for pancreatic and biliary fistula, where 200 mils is used rather than 500 mils. So when fistula are classified based on the 24-hour effluent, it is a physiologic classification. Anatomic classification of fistulas generally could be internal fistula or external fistula. But when you talk of enterocutaneous fistula, you are dealing with an external fistula because the intestine is communicating with the skin, the epithelium of the skin. Internal fistula could be an enteroenteric fistula, one bowel communicating with the epithelium of a bowel communicating with that of another bowel, or another hollow viscous within the peritoneal or abdominal cavity, maybe the ureter. Okay, you can have enteroureteric fistula. Okay, enteroaortic fistula. All those are internal fistula based on anatomic classification. However, when you talk of enterocutaneous fistula, it's an external fistula. However, a more reliable way or important way of classifying enterocutaneous fistula that correlates with mortality in patients is using the Sigisera classification that categorizes fistulas into type 1 to type 4. Type 1 is esophagogastroduodenal fistula. When the fistula involves the abdominal esophagus, the stomach, and the duodenum, any part of this is regarded as type 1 fistula. When it involves abdominal esophagus, stomach, duodenum, it's a type 1 fistula. Type 2 enterocutaneous fistula is described as jejunoileal. Any part along the jejunum or ileum is regarded as type 2 enterocutaneous fistula. Type 3 fistula is a colonic fistula. Any part of the colon communicating with the skin is type 3 fistula, while type 4, any of the above with a large abdominal wall defect is described as type 4 fistula. Now, this classification correlates with mortality. And for type 1, the mortality is 17%. Okay. For type 2, the mortality is 33%. Type 3, the mortality is 20%. And type 4, you can see the mortality is up to 60%. Now, the mortality of type 4 is the highest because of the associated large anterior abdominal wall defect. For example, if you have type 2 now that has a very high output, in most cases are now associating with a large anterior abdominal wall defect, that is a type 4 enterocutaneous fistula. Okay, so the next classification is etiologic classification of enterocutaneous fistula, and you should know the commonest cause of enterocutaneous fistula, accounting for 75 to 85%, is post-operative surgery for cancers, inflammatory bowel disease, lysis of adhesion, adhesiolysis, peptic ulcer disease, and pancreatitis. All these surgeries are commonly associated with enterocutaneous fistula, and this could be spontaneous, accounting for 15 to 25% of cases. Now, what could cause spontaneous fistula? This could result from an inflammatory bowel disease, okay, radiation enteritis, because when fistula results from radiation, this is usually from ischemic injury. They cause enteritis obliterans, where the superoxides, free radicals that are released from ionizing radiation tend to cause microvascular injury, and this will lead to ischemia, necrosis, and perforation. Now, appendicitis, diverticular disease, ischemic bowel, erosion of an indwelling tube, perforation, neoplasm, iatrogenic, and several others. Then less than 5% result from trauma, which could either be blunt or sharp injury, penetrating abdominal injuries. Clinical presentation of enterocutaneous fistula. They could present spontaneously or post-operatively, as mentioned. In spontaneous presentation, in most cases, it is insidious in onset. They will have feature of an underlying disease, maybe tuberculosis of the abdominal tuberculosis, or inflammatory bowel disease, or whatsoever the underlying disease is. They will have features. So this here, history is very crucial in getting feature of an underlying disease. Taking a good clinical history, good physical examination before requesting for an appropriate investigation. So now, internal fistulation with hematuria, as I told you, you could have an enteroureteric fistula. This patient will be passing, they could be passing, what do you call it, gas in the urine, or enterovesical fistula, communicating with the epithelium of the bladder. You'll be seeing gas in the urine, fecoluria, you see fecal matter, fecal particles in the urine. They could even have diarrhea and constipation, followed by leakage of bowel content, okay? Now, in post-operative cases, they have history of previous abdominal surgery, okay? Now, they will tell you before the leakage of this effluent via an anterior abdominal wall, there was history of surgery, maybe following a peritonitis. They have clinical features of what? Peritonitis, okay? Then they were now taken for surgery, okay? Later, they now develop discharge from wound or from a drain site, okay, of pus, fluid, feces, or bilous effluent. So usually they have surgeries, and in most cases, it is leakage from anastomosis. Maybe when one anastomose an edematous bowel, after the inflammation and the edema subsides, the sutures become loosened and they start leaking, okay? And from there, the pathogenesis progresses to develop an enterocutaneous fistula, okay? Patients might be dehydrated, okay, because of the fluid and electrolyte loss, and they might present in shock. They might have anorexia, weight loss, and extensive skin excoriation. Now, you shouldn't forget the problems of a patient with enterocutaneous fistula. There are 6 major problems of a patient with enterocutaneous fistula. Fluid and electrolyte derangement, okay? They commonly have hypokalemia, hyponatremia, hypochloremia, acidosis, okay? They will have metabolic acidosis, especially if it is an upper fistula involving the upper part of the bowel, where they lost a lot of bicarbonate, okay? That is proximal fistula, okay? Now, They have or fistula that proximal fistula, large fistula, or presence of distal obstruction. If there's distal obstruction, they will have a lot of discharge coming out from the stoma. Okay, so problems, if you are asked, what are the problems of a patient with enterocutaneous fistula? Number one, fluid and electrolyte derangement. Number two, sepsis. Three, malnutrition, skin excoriation, anemia, and psychological problems. Now, sepsis, they may have wound infection, intra-abdominal abscess collection, malnutrition from decreased intake and excessive loss from the stomach, and loss of a lot of digestive juice that is meant for digestion of food products that are consumed. They have extensive skin excoriation because of the discharge of intestinal content of the skin that may have a lot of acid, a lot of enzymes, okay, and a lot of fecal matter that will excoriate the skin and superimpose dermatitis that will worsen the excoriation. Okay, they have anemia from malnutrition and anemia that results from sepsis. And most of the case, you see if it's, for example, a prolonged high output fistula, you see patients having psychosis. They have psychological problems. So this can be a very serious problem that you even have to involve the psychiatrist in the management of such a patient. Now, what is the goal? What are the goals of management or treatment? The aim is to correct metabolic and nutritional deficits, okay? You want to correct that. You want to achieve closure of the fistula. You want to reestablish continuity of gastrointestinal system. The expected treatment course can be divided into 5 overlapping but sequential phases. Now, the phases of managing an enterocutaneous fistula are categorized into recognition and stabilization phase, investigation, the phase of decision-making, definitive treatment, and healing and recovery. So these are the phases of management of enterocutaneous fistula. Okay? So the first phase is recognition and stabilization phase. Okay? Now, you have to recognize the presence of fistula and the various complications and the various problems, okay? You have to recognize the presence of a fistula and the attending complications, and then you stabilize. Now, how do you establish presence of fistula? Taking an adequate history, okay, that tells you there is a discharge of below. Okay. Now, the recognition phase, okay, entails okay, sorry for that interruption. Now, the recognition and stabilization phase, now you have to establish presence of fistula by taking an adequate history and examination. Now, you have to address the urgent clinical problems. Okay. We talked about fluid and electrolyte imbalance. You have to give IV fluids and correct all derangements, especially hypokalemia, hyponatremia, acidosis, okay? Metabolic acidosis. These are common electrolyte problems you encounter in patients with fistula, okay? Now, anemia, you transfuse blood, you give broad spectrum antibiotics, and if there is abscess, you have to drain abscess cavities. Then the nutritional deficit, okay? Nutritional deficit, the energy requirement is 2,000 to 5,000 kilocalories. And the protein requirement, it's output dependent. Now, for low output enterocutaneous fistula, they may require 1 to 1.5 gram per day of protein, while moderate to high output enterocutaneous fistula will require 2.5 grams per day. Now, you have to control the effluent, the drainage from the fistula, because it will cause an extensive skin excoriation, especially if it is a high output. This is achieved by dressing, okay, applying bagging, some catheter, somatostatin analog. You use somatostatin analog that is either given IV or subcut. This will reduce gastrointestinal secretions. Now, you also give omeprazole, proton pump inhibitor, that will reduce gastric secretions. Now, you should also know that aside reducing the effluent of that fistula, you have to protect the surrounding skin by using skin barriers or pastes, powders, or zinc oxides that will protect the excoriation of the surrounding skin by the effluents. Now, you need psychological support. You should know that psychologists, psychiatrists may be involved for adequate motivation of your patient, counseling of the patient, so that they are well motivated to cooperate with treatment that is offered. You can see these fistulas, these have a skin barrier that will protect spillage of the content on the surrounding skin. And for this, zinc oxide is applied, okay, around the skin to prevent excoriation around the skin. So because of the importance of the skin involvement and the complications, it leads to the skin, the stoma are classified into categories using the Ivenbidal classification. Now, they are categorized into 4, the various types of stoma and the way you might approach such stoma. Category 1, in category 1, they have a single orifice, okay, passing through an intact abdominal wall, otherwise healed scar, around which the skin is flat and reasonable good condition. You have a healthy abdomen with just a stoma with a surrounding healthy skin, and fistula, the content is pouring through that stoma with a surrounding healthy skin. That is category 1. So in such situation, you can use a drainable bag like colostomy or ileostomy bag, okay? They are stoma adhesive. that are applied, okay, around the stoma before applying the bag, and you could add carrier paste or zinc oxide around such. And this skin will be well protected. Why? Because the effluent is collected into the bag, into a bag, and you are applying protection of the surrounding skin. Now, in category 1, you should note there will be no any difficulty in application of bag to collect the effluent. So that is very important, you know. In category 1, there is no um, there is no difficulty for application and collection of content because there is no scar, there is no bony prominence, it's not coming out through the umbilicus. That is category 1. Then category 2, it could be a single or multiple orifices passing through the abdominal wall close to a bony prominence, surgical scar, or other stomas, or the umbilicus. So here you will have some degree of difficulties as compared to category 1. It is an application of your ileostomy or colostomy bag will be challenging because there is a scar, there is a bony prominence. It's not coming through a healthy skin. So you need a split or striker frame bed, hospital bed, in the first 48 hours. These beds, you can adequately position patient, tilt patient in such a way that this effluent can be collected, okay? Then don't forget, when patient is managed on such striker bed, okay, all those measures are instituted to reduce the effluent. And when it is reduced, you then manage patient as category 1. Now in category 3, the fistula is presenting through a small dehiscence, okay, of the main wound. There is fistula coming through a wound dehiscence, a partial dehiscence, a small dehiscence of the main wound. So here you use a large drainable bag that will cover the stoma as well as the surrounding skin. Okay, in category 4, the fistula is coming through a large dehiscence or at the bottom of a gaping wound. Here, most appropriately, you use a low sump suction drain, okay? Now, I'll demonstrate that to you. Now, this is the striker bed, okay? This bed, you can see it has a striker frame, and it could be splitted at various angles, and at the same time, it could be rotated and manipulated to position a patient in such a way that the drainage could be easily collected. Now, in a low sump suction drain, look at this massive wound. There is complete wound breakdown here, and you can see a stoma coming out through a complete wound dehiscence. How will you apply a bag here? This will be very difficult and challenging in collecting a drainage here. So what you do, you apply a negative pressure suction, okay? In conjunction with a plastic surgeon, they apply this bag for you, okay? It's made watertight and the wound is sealed, leaving only the stoma. Now, there are various techniques you can use in achieving this, okay? If you have maybe the bowel is communicating, okay? If this is the bowel communicating with the exterior, okay? And after you apply your negative pressure bag, okay? Now, you can apply a tube, okay? A soft tube into this through the stoma into the bowel, okay? And this is connected to the negative, the low suction. Then the second tube is applied into this bag, okay? Okay, such that the wound will be completely dry. Okay, what I'm trying to demonstrate is, okay, here this is the one that is sucking, okay, the effluent within this sealed bag. And in some cases, there might be a tube that is applied into the proximal stoma, okay, so that there will be completely zero effluent contaminating the wound. So in category 4, you use a low suction drain. This is a patient that I manage with a very difficult fistula. I'll give you a small gist about this patient, the case scenario of this patient. Now, don't forget, we said in the management of enterocutaneous fistula, it is done in phases. The first phase of phase 1 is recognition and stabilization of the patient. You recognize the presence of fistula as well as the presence of the problems or complications, and you start addressing them as soon as possible to avoid serious complications that may develop. Phase 2 now is to investigate the patient. The aim is to define the anatomy of the fistula. Now, you can even use dyes, do a dye test to even confirm this discharge. Is it a fistula? You give a patient oral contrast like Congo red, methylene blue, or activated charcoal to take. Okay, and when you see this contrast or dye leaking out through that effluent, you have confirmed that there's a connection between the intestine and the skin. So phase 2, you want to even define the anatomy by first confirmation. Is this even a fistula or a differential intra-abdominal abscess or whatsoever? So when you do a dye test, number 1, you confirm that, yes, this is a fistula. Then you now go ahead to do a radiological investigation. Now, there are various radiological investigations that are done. Number 1, fistulography. Now, in fistulography, the surgeon, in conjunction with the radiologist, they cannulate the fistulous tract and inject a dye. When a dye is injected, then an X-ray is taken to see the outline of the fistula. Now, it could be just a simple short fistula that is less than 2 centimeters. It could be a long fistula that is greater than 2 centimeters. It could be multiple fistulas. You just see multiple tracts, okay? The fistulography will also show you a complex fistula that is related to an abscess cavity, okay? Yes, you could do a gastrointestinal series. Now, you should realize that it is not always very easy to just cannulate a fistula and start injecting a contrast. It might be difficult. In fact, let me tell you, sometimes you might not be able to even identify the stoma. You just see discharge coming from multiple openings. So in such case, how will you cannulate and administer your contrast? So in such situations, you can do gastrointestinal series, okay? Using barium, you can do barium meal and follow through. You can do barium enema. So when you are thinking of a proximal fistula, you do a barium meal and follow through. It will outline the stomach, the small intestine, okay? Now, when you do when you are thinking of a large bowel fistula, you do a barium enema where you inject the barium via the rectum. Okay, so in such case, when you do this barium series, you will see, if you take the x-ray, you will see the connection, okay, of the barium, how it connects at the site where it connects to the skin, and you see cessation of contrast in the distal segments of the intestine, okay? Yes. Now, abdominal CT scan is also a very vital investigation in evaluating enterocutaneous fistula, because it will show you a complex fistula, multiple tract, and association with abscess cavity. So this is very important investigation. So don't forget, phase 2 is aimed at what? Defining the anatomy of the fistula. Phase 1 is what? Recognition and stabilization. Phase 2 is defining the anatomy of the fistula by various investigations. Okay? Now, phase 3, you have to make a decision. This is stage of decision making. You want to make a decision. Is this a type of fistula that will close spontaneously, or is it a fistula that must be operated before it heals? Okay. Now, it's aimed at fistula closure and reestablishment of gastrointestinal continuity. But you should know that ideally, a spontaneous closure is preferred. And this, you commence conservative treatment, non-operative management, because with adequate conservative measures, fistulas tend to close in up to 70% of patients when you do an adequate conservative treatment. One, by giving adequate IV fluid, correction of this electrolytemia, correction of anemia, control of sepsis. This is very, very important in non-operative measure. You have to control sepsis. You have to correct nutritional derangement, malnutrition. You have to correct that. Okay? A nutritional correction, which is usually done by parenteral nutrition, especially in a high output enterocutaneous fistula. Okay. Now, you can ask about nutritional supplementation, not only total parenteral nutrition, even enteral is encouraged, especially in low output enterocutaneous fistula. But high output enterocutaneous fistula, you have to give patient TPN, total parenteral nutrition. Now, you should know the expected time of spontaneous closure. It varies with anatomical location of a fistula. In the esophagus and the duodenum, the expected duration is 2 to 4 weeks. In the colon, okay? In the colon, the expected duration is 30 to 40 days. And in the small bowel, it's about 40 to 60 days, okay? Now, the golden rule for fistula treatment, you should know: make haste slowly, okay? Intervene surgically only when proved to be inevitable. Don't just rush to go and start operating an enterocutaneous fistula, because there is risk of creating more fistulas. You create more enterotomies, especially if patient has not been well stabilized and resuscitated, and you are rushing to reoperate on this patient. You will have a lot of serosal injury, and patient might come up with more fistula. So the golden rule is, don't be in a hurry to operate on a patient, especially when you realize patient is doing well non-operatively. This concept of Fistulo Crisis is also very important, especially in a patient with high output proximal, jejunal, or iliac fistula, and which has a good mucocutaneous continuity. Now, these, you should know that the fistulas, the stomas can be intubated, and this effluent can be collected and infused as enteral feeding into the distal segment, because this segment contains a lot of fluid and electrolyte and nutritional content. So this is what is causing all the problems of dehydration, dyselectrolytemia, and malnutrition in the patient. But you should know these must have a good mucocutaneous continuity, and it can be well cannulated and collected without contamination, reinfusion, so that you don't cause more harm than good. Now, you should know in the decision making, what decides, what makes the decision, whether what influence your decision on whether a fistula will close spontaneously or you have to intervene surgically. Okay? Don't forget, phase 1 is recognition and stabilization. Phase 2 is defining the anatomy of the fistula by investigations. And phase 3 is a phase of decision making. What is the decision? What decision do you want to make? Whether this fistula will close spontaneously or it will require surgical intervention. Now, the factors that prevent fistula from closing spontaneously are summarized as friends: foreign body, fistula resulting from exposure to radiation, infection or infestation, epithelialization of the tract, okay? Epithelialization of the tract and fistula. When you have end fistula, you have a stoma, okay, communicating with the exterior such that this stoma is greater than 2/3 of the circumference of that bowel, is described as an end fistula. So this could be described as epithelialization of the tract or an end fistula. It doesn't necessarily have to be the complete circumference that is exposed as the stoma with detachment of the distal segment. No, when the circumference is more than 2/3, it is described as, and it will never heal spontaneously. So don't waste your time, the patient's time, and the relatives of the patient. Okay, so when fistula results from neoplasm, okay, fistula that resulted from malignancy, they will not close spontaneously. You have to intervene. When there's a distal obstruction here, of course, nothing will go down. So it will come out through the fistula. That's why whenever you are examining a patient with enterocutaneous fistula, don't forget, you must do a digital rectal examination to assess for the presence or absence of feces in the rectum. If the rectum is empty, you know it's likely an end fistula, and that fistula is not going to heal. But if the patient has feces in the rectum or patient is passing stool, that is a good sign. Okay, you should be happy when a patient has fistula and the patient is passing stool. You know that is not an end fistula. So the patient, the fistula is likely to heal with a very good conservative or non-operative management. Okay, now when there is sepsis or short, this is described as sepsis or short tract, when the tract is less than 2 centimeters. You see, it's a very short tract, so it will not heal spontaneously or when the diameter of the stoma is greater than 1 centimeter. So this fistula will not heal spontaneously. You have to intervene surgically. When patient has a poor nutritional status, you have to um, um, correct nutritional deficiency, especially when your serum albumin is less than 2.5 grams per DL, or when, more importantly, your serum transferrin is less than 200 milligrams per DL. This patient has a poor prognostic sign. So patient must have a very good nutritional status for a very good outcome. Don't forget, this is a phase of decision making, which is what? Phase 3. You must have all these phases at the tip of your finger. Phase 1 is recognition and stabilization. Phase 2 is defining the anatomy. Phase 3 is decision making. Now, after making your decision, you want to give a definitive treatment, surgical treatment. Now, the indication, when the patient has friends, yes, the mnemonic we described, when they have friends, you have to give a surgical treatment, okay? Yes. Now, when anatomic favorable fistula not close in the expected time frame, you expect fistula to close, okay, after an adequate non-operative measure in 4 to 6 weeks of sepsis-free period. That's why I told you, in the management, in the non-operative, you must ensure this counting you are doing, these weeks you are counting, you must ensure is in a sepsis-free period. Not patient is having sepsis within that 4 weeks and you think you are achieving anything. No, it must be 4 to 6 weeks of sepsis-free period and having adequate parenteral nutrition. If patient fails to achieve this, you have to close. If you have a lateral duodenal fistula, you have to close surgically because it will not heal. If you have fistula at the ligament of triglyceride, it will not heal. Okay, you have to close surgically. Okay, yes, with all other factors we described in friends. What are the salvage procedures you do? If a patient present with fistula with an abscess cavity, you have to do I&D. You have to drain the abscess. If not, you are wasting your time. Do a proximal diversion. Now you should note, when you do a proximal diversion, you control, you allow the distal fistulous tract to heal. Yes, before you now reverse the diversion. Now, if you have maybe a patient with multiple stomas here or complex fistula in the distal segment, it will not heal, okay, with so many unfavorable factors and high output, okay? You just divert this bowel at this point, put your stoma back to collect, at least this is a controlled fistula, then you allow this part to heal. Now, proximal diversion could also entail internal anastomosis. That's a complex terminal ileal fistula. You can do a proximal iliotransverse anastomosis. Don't forget, diversion does not necessarily mean that you have to exteriorize, but commonly we exteriorize the proximal bowel, but you divert bowel to a more distal side so that you bypass the site of the fistula. Externalization of fistular segment, okay, we describe resection of the monos segment of the intestine. Now, you should remember, you don't just go and primarily close a fistula. It will not work. You have a patient that has fistulous tract. Okay, you exercise this tract. You say, okay, let me just do a simple closure of that segment. Is going to break down because it's a phlegmonous segment. It has a lot of inflammation. It has a lot of scar tissue. It has a lot of fibrosis and so on. So what you do to avoid the recurrence, just do a segmental resection of the involved part and anastomos. Now, the principles of operating a patient with enterocutaneous fistula: number one, access should be through a fresh incision. It is called through a virgin incision, okay? If you have abdomen with a previous scar here and a fistula, you want to operate, start from a virgin incision, go above the previous scar, so that you don't hit a bowel and cause more enterotomies at entry. So you have to go through a fresh incision, okay, through a median or paramedian, but this is not commonly used. It's via a median. The previous scar may be used when it is well healed. So, generally the principles of operating the abdomen: number one is adequate exposure. And to get adequate exposure you have to go through an appropriate incision for access, okay? Then you have to mobilize the bowel. So after adequate access, the next thing is proper mobilization. You have to mobilize this bowel from the ligament of Triaxis down to the ileocecal junction and up to the rectum. So adequate access, proper and meticulous mobilization. Why do you have to do that? To define the anatomy. You want to define the anatomy of the intestine as well as the segment that is involved. You cannot just start surgery. You just open abdomen. You don't know what you are doing. No, you must define the anatomy. Anytime you are operating on a patient, you must define it. You don't just operate blindly. So you have to mobilize from the ligament of Triaxis down to the rectum, okay? Define the anatomy of the bowel properly. So you define the tract and the segment that is involved. When you isolate that segment, you now do a resection and anastomosis. Please remember, resection and anastomosis. If you attempt to close with a simple closure, is going to recur because of it's a phlegmonous segment. Now, other procedures can be done like drainage of abscess, as we mentioned, proximal diversion, okay, to a distal segment of bowel. You can provide a means of post-operative feeding. For example, if a patient has an esophageal fistula, you can do a gastrostomy. Okay, if a patient has a gastric fistula, you can do a what? Jejunostomy. Okay, then you secure abdomen. And the last phase is the healing phase. So phase 4 is you do a definitive surgery treatment, definitive treatment. Now in the healing phase is the post-operative management of the patient. You have to what? Ensure patient has a nasogastric tube in situ for drainage. Why? Because this patient they often have a prolonged post-operative ileus. If you don't have NG tube in situ, they are going to be vomiting. And you don't want a post-operative patient to be vomiting. If they are vomiting, it worsens the fluid and electrolyte derangement in your post-operative patient. And If a patient has a distended segment of gut, if you don't pass NG tube, they tend to lose more fluid and electrolytes. So with NG tube, it prevents more distension, it prevents more loss, and it prevents post-operative vomiting because the intestine is not contracting. Gastric secretion, salivary secretion are all accumulating in the stomach. Intestinal and bilious secretion are accumulating. They may reflux back to the stomach, and there is no onward peristalsis. So patients will have reflux, the bile will irritate the stomach, and the patient will vomit. And you know, they have risk of even aspirating in the post-operative period. So the message here is pass an NG tube in a patient you are operating for enterocutaneous fistula. You have to continue antibiotic for at least 3 days. Continue your nutritional support. Now, you should know that enteral feeding is also given, especially in low output fistulas that involve the large intestine. Now, what type of enteral feeding is preferred? There is what is called elemental diets. This elemental diet contain pre-digested, food products. They are already pre-digested proteins, carbohydrate, and fatty acid molecules. When you give them, they don't require digestion. They are just absorbed and utilized by the body. So assuming you have a large intestinal fistula that is low output, if you give elemental diets, they are absorbed in the jejunum. So they don't even reach the large intestine. Most of them are absorbed in the jejunum, and as they are enteral feeding, they maintain appropriate physiology, and they prevent transmigration of bacteria and all those problems related to prolonged parenteral nutrition. So you supplement that with TPN. You have to wean and resume oral intake in the healing phase. Now, dietitians and family may be of assistance. Now you should know why you need a dietitian. You should know the protein carbohydrate content of all the staple and regular foods that patients are taking, and you should know how to mix them, to get a good balanced diet. Not that you just ask patients to be eating 12 eggs every day, morning, afternoon, and evening. Of course, you know that it's not, he's not going to be able to cope with that. Now, how do you prevent the occurrence of enterocutaneous fistula? But when you are operating a patient, please, especially in emergencies, you have to adequately optimize your patient. Don't go and operate a dehydrated patient without rehydrating patient, making adequate urine, all the bowel are well perfused, Don't go and operate an anemic patient because you are a super surgeon. You don't want to optimize your patient. You just want to rush patient to the theater. You come up with complication. Because if the bowel are not well perfused, you do anastomosis. There will be ischemia at your site of anastomosis. When there's ischemia, there's going to be necrosis, and there will be leakage of your anastomosis. So patients should be well optimized before operating. Some of our neighbors in the theater used to tease us that surgeons don't have emergency. They will keep their patient for 48 hours before operating. Yes, we have urgency. Those are surgical urgency. We have to optimize our patient, correct dehydration, correct dyselectrolytemia, correct anemia before you take patient to the theater and operate, so that patient don't come up with post-operative complication, amongst which is what? Anastomotic leakage, amongst which is what? Enterocutaneous fistula, there are surgeries that we really categorize as emergencies. You can even rush the patient to the theater immediately without any single investigation. Okay, you have a ruptured aortic aneurysm, complete airway obstruction. All these things are emergencies, but peritonitis is an urgent surgery. You need to optimize patient, please. You need meticulous surgery to prevent iatrogenic bowel injury. You are putting tension as if you are tying ropes. No. If you are putting excessive and undue tension on your anastomotic line, you are going to strangulate the blood supply to that anastomotic line is going to dehisce. Strict adherence to established surgical principles in performing bowel anastomosis. There are principles of bowel anastomosis. You have to adhere to them. Proper care of appendiceal mass. Don't just go and start operating. If you remember the Oshna sharing regimen for appendiceal mass. Avoid extensive adhesiolysis. Careful examination if you have serosal tear. Now, in the 1980s, in the 80s, you should know, or let's say, even before the 80s, in the late 20th century, the mortality rate for enterocutaneous fistula is 100%, but it has improved over the years. In the 80s, you have like 70%, and you can see it is decreasing gradually. Mortality rate has decreased from 30 to 50% to as low as 10 to 15%, and in some centers, as low as 5%, okay? Now, with adequate nutrition, okay, they will achieve 70 to 80% spontaneous closure of enterocutaneous fistula. Don't forget the golden rule. Don't be in a hurry to operate. You have to commence non-operative management, except if there is a clear-cut indication for surgery, as we mentioned, like high output enterocutaneous fistula, patient with friends, the mnemonic we described, lateral duodenal fistula, okay, fistula at the ligament of trixie, and so many other things. Now, there's still significant morbidity, especially if patient is not treated with care. Now, mortality is still high in developing countries. Now, the current trend in treating fistula, you use fibrin glue, laparoscopic techniques, okay, electric nerve stimulation that tend to stimulate the endings and improve blood supply, laser ablation for chronic enterocutaneous fistula that fail to heal after non-operative management. I told you I'll tell you about a case I manage, a very difficult and challenging case of a 32-year-old that was referred to me. And at presentation, she was in shock to start with. When she came day one, okay, she came in shock. So the casualty officers and those in emergency, when the patient was brought out of an ambulance, they started resuscitating, okay, securing IV access, start giving IV fluid to correct shock from day one. And this woman presented with copious discharge of fecal matter from a wound dehiscence, a midline wound. And of course, not only fecal matter, there was bleeding from that wound. She was just bleeding profusely from the wound. The blood is mixed with fecal matter. I have the video. I even forgot to upload the video on this slide. Okay. Now, she has associated multiple subcutaneous bleed. What is the message here? The patient already had DIC, disseminated intravascular coagulopathy, from severe sepsis. She had fever and severe anemia. Okay. In fact, when they came, the relatives were hopeless, okay, about that case. She has past history of two previous cesarean section. She had recurrent abdominal pain for 1 year, and they were treating her for dyspepsia with omeprazole in the referring hospital until she developed features of intestinal obstruction, for which she had two laparotomies before presenting. And lo and behold, they found an abdo pack. It's a mop for cleaning the abdominal cavity. A foreign body was forgotten in her abdomen, okay? Following the second cesarean section they did, the surgeon forgot an abdo pack, just like a towel in the abdomen of that patient. And what happened? That towel eroded into her rectum. It eroded into her transverse colon. It eroded into the ileum as well as the jejunum. So there is no part of the bowel that towel did not, it just formed a complex mass. Okay, the intestine was twisting around that towel. And of course, the surgeon went and did laparotomy. When he saw what he saw, he kept on resecting and anastomosing, and his wound broke down again. He now took her back for another anastomosis. It broke down, okay? It broke down. And of course, when she came, he was requesting to go for the third laparotomy, and the relative refused, and they requested for referral to another facility. When she came in shock, and the medical officers were battling at the A&E. At presentation, she had severe sepsis with DIC. She was bleeding spontaneously. Okay, I could tell you I saw 2 liters of clotted blood in her abdomen during laparotomy. She had multiple subcutaneous bleeds, severe anemia, dyselectrolytemia, malnutrition, and type 4 fistula with extensive skin excoriation. She have serious psychosis that have to involve the psychiatrist in her management. So at presentation, we stabilized her with IV fluid. We corrected her anemia. We gave fresh frozen plasma. We gave human albumin. We gave total parenteral nutrition. We gave octreotides to reduce the output, antibiotics, and we commenced skincare. You can imagine what the patient spends. She was getting fresh frozen plasma. Each was about 300,000. She was getting albumin, 60,000 per vial, to TPN, 80,000. So it got to a point that the relative were highly cooperative, but they spent up to a sum of 9 million naira in 3 weeks of her admission in the ICU. Okay, now I will tell you the challenge that I faced. Intraoperatively, what did I find? I found multiple jejunal stoma. I found a stoma in the transverse colon. There was a large rent in the anterior wall of the rectum and the only intestine that this woman had was just 90 centimeters. They've resected most of her small intestine, and what is left of the jejunum was 30 cm from the ileocecal junction where absorption takes place, and that 30 cm has multiple stomas. So I just did a proximal diversion here. There's nothing I can do. Close the defects and start managing all the derangements she has. You can see it was a very challenging task. And at the 3rd week, I have to call all the relatives and counsel them that, you see, this patient doesn't have any physiology. Her physiologic reserve is zero. Whatsoever we are doing is based on all these nutrients we are giving her, the TPN, the human albumin, fresh frozen plasma, antibiotics, very expensive antibiotics. After counseling, so the relative have to go and sit down and do a family meeting. So they now make a decision, and lo and behold, you will expect what will happen, because they were completely exhausted before they start selling their property. So this is the end of the lecture. I will now entertain questions. So I will allow you to unmute yourself. If you have any question you ask, then I will respond to your question. So any question? If you have any question, please, you can unmute your mic and ask your question. Thank you all. So it appears there is no question. Okay, we don't have any question. Okay.
No, there is question.
Okay, go ahead and ask the question.
Good evening, all my colleagues, and Doctor, well done. Thank you. The question is that when this kind of condition occur, patients have been prolongedly on various antibiotics. So specifically, for the way out for the antibiotic to be used, can MCS, wound MCS, or whatever call it, to take the sample from the wound to do MCS, then use the result of the antibiotic and have this kind of situation, or there are specific antibiotic that is supposed to be used when this kind of condition occur.
Okay, thank you very much for that question. You should know that the problem here is not a local wound sepsis we are talking about. The sepsis is a systemic problem. It's not a local wound sepsis. The sepsis is a systemic problem. Okay. So the antibiotic you are giving is to control systemic sepsis. So if you do culture, is of no significance except if patient has maybe local wound discharge from abscess, and even that you have a mixture of bacteria. You have polymicrobial involvement. But what you need to understand here is better you even do a blood culture, because what you are addressing is what systemic, not local instances. I hope that is clear.
Thank you.
Yes. Any other question?
Yes.
Please, sir. I have a question.
Yes. Go ahead.
What's the function of? Thank you very much at first for the lecture, and I hope you know who is speaking. Tijani, Dr. Tijani.
Okay, Tijani from Ibadan.
Yes, sir. Dr.
Go ahead. Your question.
What's the function of autotide that we are giving at that point?
tight.
And is at all conditions, is there any time that we are not supposed to give, or we have to give at all condition, at all types of the enterocuteneous fistula? Thank you very much, sir.
That's a very good question. Now, octreotide are somatostatin analogs, and what they do, they inhibit GI secretion. It's just like a GI lockdown. It inhibits pancreatic, biliary, okay, small intestinal secretions. So when you give octreotide, they tend to decrease secretions and it will reduce the output of the fistula, because if the secretions, total intestinal secretion in 24 hours is 9 to 11 liters. The total gastrointestinal secretions in 24 hours. Just imagine patient is discharging 9 to 11 liters from intestinal secretion, not even from exogenous intake. Okay, the output will be high. So you use octreotide to inhibit gastrointestinal secretion. Okay, so at what condition is it given? It is given in high output enterocutaneous fistula. It's usually given in what? High output enterocutaneous fistula, and it's given subcutaneously. Give like 100 to 250 microgram, okay, in divided dose like TDS or BD, okay? Now, what conditions? It's given in what? High output enterocutaneous fistula. And you should know that octreotide are more useful in the first 72 hours of a high output enterocutaneous fistula. Usually, when you give octreotide in the first 72 hours, they tend to reduce significantly. You might not require higher dose than the initial amount, okay? But it is very important in patient with such fistula. But in our own environment, we find out that sometimes drugs are too expensive for patients to afford, or in some areas that are not readily available. We improvise some other drugs, like we use dihydrocodeine, DF118, and loperamide. This cause is an antimotility. And this, okay, one of the side effects, it causes constipation. So it reduces the motility of the intestine, hence reducing the output. And then you add omeprazole. This will now reduce gastric secretion, but it is not as effective as giving octreotide. Okay. Yes, I hope that is clear. Okay.
Yes, sir. Thank you very much, sir.
Is there any other question?
Yes, sir. I have a question. Please. Okay, sir, about the mnemonic friends.
Yes, well,
does the patient must present with all of them or only a few to be eligible for operation?
Now, when he presents with any of these, okay, any of these, you have to operate on the patient. Okay, these are just factors. If you have a foreign body like that, abdomen that is forgotten in that patient body, or any other material that was used during the procedure, you have to operate. If not, it's not going to heal. If it's from radiation alone, you have to operate. If it's associated with infestation and fistula. It doesn't have to be all the component. Any one of them is an indication for surgery. Is it clear?
Yes, sir. Thank you.
Yes. Any other question?
Sir, my just few answer. I said that when these antibiotics or when this culture reveals no growth, so is there any specific antibiotic that can be used?
You know, in use of antibiotics, there are principles of use of antibiotics, whether in enterocuteneous fistula or any other condition. When you use antibiotics without culture, it is called empirical use of antibiotics. And because environment differ and the sensitivity pattern of antibiotics differs from one environment to another, okay? So you use antibiotics based on the sensitivity pattern of the environment, okay? If you are using quinolones and they tend to be more effective based on your experience in that area, you prescribe quinolones. And when the patient is responding well to quinolones, even if the sensitivity pattern comes out showing sensitivity to another antibiotic, but the patient is responding to that antibiotic, you have to continue antibiotic up to about 3 days when patient is symptom free. So there is no specific single antibiotic you will choose to say, okay, when there is no growth, I should use this particular antibiotic. What you should do, you should just follow your principles of antibiotic administration, okay? There are outlined principles for antibiotic administration. Is either you are using antibiotic as empirical use, prophylactic use, or therapeutic use. And for therapeutic use, you should know it is not a substitute for indicated surgery. It's just an adjunct, okay? So regarding this, your question, if there is no growth, okay? Yes, the reason why you will not have growth, maybe the patient has already been on antibiotic for a very long time. And when you take culture, you will see no growth, okay? So if the patient is doing well on an antibiotics, you can maintain that. If it's not doing well, you can change the antibiotic based on your knowledge of sensitivity pattern in that environment. Or you can even, because management is multidisciplinary, you involve the microbiologists, the infectious disease expert. They can come and review your patient and advise you more appropriately on what to do. But my advice is you have to follow strictly on the principles of antibiotic use in any patient you are managing. I hope that answers the question.
Thank you very much.
Okay, you're welcome. Any other question?
Good evening, sir.
Good evening.
Yes, I'm Dr. Bima, sir. Just wanted to clarify something, sir. Is sepsis an absolute indication for surgical management of a patient with enterocuteneous fistula? Or is there room or window for us to resuscitate the patient first before then considering a surgical intervention? Because your friend's pneumonic, there's also sepsis there. So I don't know if you can shed more light on that, sir.
Okay, good. That is a very good question. Now, sepsis. When we talk about sepsis here, in the mnemonic, we are talking about local sepsis in terms of abscess, where you drain abscess. But when you talk about systemic sepsis, it's not even an indication for surgery. You have to stabilize the patient by giving a broad spectrum antibiotics, okay? And when patient is sepsis-free, you continue the conservative treatment for about 4 to 6 weeks of sepsis-free period. Now that S is commonly you can use it as short fistula, not only local sepsis as in form of abscess, okay? The short fistula or short tract is when the tract is less than 2 centimeters. It's regarded as short tract. It's not going to heal. Or when the diameter of the fistula is more than 1 centimeter, is very difficult to heal. Okay, so that S is not talking about systemic sepsis. It's talking about local sepsis in form of abscess, precisely. So when there is an abscess cavity, you must drain that abscess cavity. If not, it will continue forming complex fistula. More bowel might be eroding into the abscess cavity. So that S, to avoid confusion, that last S, you can replace it with short fistula or short tract. Hope that is clear.
Yes, sir. Thank you, sir.
You are welcome. So I believe we've come to the end of this lecture. So you can, it is recorded for those who wants to go over and over. Again, you can still use it for revision, and I'll share the slide with you so that you can also use this slide for revision. So thank you very much, everyone, for participating. We are going to call it a day. Thank you all.
Thank you, sir.
You are welcome.
Thank you, sir.
Thank you, sir.
Thank you.